This is a message to pharmacists like you who have cared for your patients through the healthy times and through the hard times. Throughout the COVID-19 pandemic, you were there to help patients, providing them access to the information, medicine, and the vaccines they needed to help stay protected. Now, as the threat of COVID-19 moves from the pandemic to the endemic stage, it's time to help your patients understand the importance of regular vaccination against circulating variants of the SARS-CoV-2 virus as part of a healthy lifestyle. While COVID-19 may not be top of mind for your patients, the threat of disease is still here. Hospitalization rates in the U.S. for COVID-19 increased by close to 217% in the summer of 2023, jumping from 6,477 hospitalizations in the first week of July to 20,538 in the week of September 9th through the 15th. Make sure your patients know that COVID-19 vaccines have been updated and are now available. You saw them through the pandemic. Now you can continue to help patients see that the ongoing threat of COVID-19 is something that we face together. Thank you to pharmacists everywhere. This message has been brought to you by Moderna.
You're listening to the Pharmacy Podcast Network.
This is the PGX for Pharmacists podcast. We believe pharmacists are the best positioned providers to lead in PGX. Pharmacogenomics is the study of how genes affect a person's response to drugs. This relatively new field combines pharmacology and genomics to develop effective, safe medications and doses that will be tailored to a person's genetic makeup. This podcast is dedicated to pharmacists with an interest in learning more about the data analytics, industry trends, and evidence-based usage of pharmacogenomics. Welcome to PGX for Pharmacists, part of the Pharmacy Podcast Network.
Hi, everyone. My name is Banas Sarami, your host to PGX for Pharmacists podcast on the largest pharmacy podcast in the nation and one of the top 20 podcasts in genomics globally. If you're new to the podcast, I'm a pharmacogenomics medical science liaison and a mentor to pharmacists. So connect with me on LinkedIn. Let's get started with conversations going. I want to hear from you, what you're thinking about and what you're doing with learning about PGX. And if you're needing a mentor, is you're trying to go beyond just reading a genetics report so you can show the value that you have. Clinicians can read the report themselves. So what makes pharmacists unique in this field? So I want to hear from you. PGX for Pharmacists podcast is focused on learning the science behind PGX, since that's where the missing gap is for both providers and pharmacists. And that's the missing gap, which is also going to push PGX into adoption. We also cover the business side of it along with reimbursement and more. So stay tuned for those episodes. So let's talk about post-traumatic stress disorder, or PTSD, which is one of the most common psychiatric disorders, which affects about 8 million adults at some point in their lifetime in the US. But it's really not clear as to why some people experience traumatic events, actually develop PTSD. Some people say it's a social construct, but in the largest and most diverse genetic study of PTSD to date, scientists from University of California, San Diego School of Medicine, and more than 130 additional institutions participating in psychiatric genomics consortiums found that PTSD has a strong genetic component similar to other psychiatric disorders. So genetics seems to account for about 5 to 20% of the variability in PTSD risk following a traumatic event. So I'm going to put that link to the article in the show notes, but my guest today, and I'm so excited about, she'll be able to tell us a little more about that. Dr. Larry Shapiro is a clinical psychologist that started back in 1990, but quote unquote retired to become a financial advisor. He was having a discussion with his brother one day, who was a career officer in the army returning from Afghanistan. So that made Dr. Shapiro rethink about his contribution to his community. So he got his license back, trained in military trauma, and started again as a psychologist in 2014. He started at St. Louis Behavioral Medicine Institute, specializing in treatment of OCD, panic disorder, social anxiety disorder, simple phobias, depression, and combat trauma. Last year, he attended the annual Boston Trauma Conference and heard for the first time about the use of psychedelics, psychedelic medicine for treatment of trauma. So after 150 hours certification program at Integrative Psychiatric Institute, he became certified in psychedelic-associated psychotherapy, which now is part of his current practice. So just this year in January, he went into private practice so he can focus more on psychedelics. He's also an adjunct instructor in the Department of Psychiatry at Washington University in St. Louis, and a clinical consultant for psilocybin research at Health Minds Lab at, again, WashU. One more fun fact about Dr. Shapiro, that he has been married to the same person for 39 years. I know myself and others want to know the secret to staying married that long, but I think that's for another podcast. So thanks for taking time to come to the podcast, Dr. Shapiro, and sharing your experience with us and how you evaluate your patients using pharmacogenomics testing potentially on some few. So I know a lot of people want to know your perspective as a clinician dealing with mental health, and especially with PTSD. So welcome to the podcast.
Thank you for having me. My first podcast. I'm excited.
Oh, so are we. Tell us what a normal day looks like for Dr. Shapiro, so we can kind of understand what mental conditions you see and its prevalence. So just walk us through that.
So before the call, because I thinking that was going to be one of the questions, I actually pulled up my calendar for next week, and going through the day-to-day, I start seeing people at 7:00 in the morning, and I go till 7:00 at night, Monday, Tuesday, Wednesday, and Thursday, and then I see people, half days on Mondays and Fridays. Looking at next week and looking at my whole book, I would say right now, roughly 30% of the people that I'm seeing, I'm treating either for PTSD from combat, or a spouse of someone who's married to someone who has combat trauma, or first responders. So between that group, I'm going to say roughly right now about 30% of the people that I see have either combat-related PTSD, or they're somehow related to, let's say, first responders related to PTSD, and then people involved on the periphery, spouses or kids living with someone who has PTSD. Aside from that, the rest is it's interesting. As I started introducing psychedelics into my practice, I've gotten a number of referrals for ketamine-assisted psychotherapy, and I'm getting a lot more referrals and call-ins. So I'd say roughly right now, maybe upwards of 10% are coming to me specifically for psychedelic-assisted psychotherapy, either using ketamine, or they're bringing their experiences with magic mushrooms or LSD into treatment and working with them with that. The rest would be kind of more general depression, anxiety, life changes. A couple of college students just recently graduating and trying to get a handle on their lives and being independent and being an adult for the first time. So that kind of summarizes in a day. It's going to be, let's say, roughly 30% is going to be combat trauma, plus minus, then anxiety disorders, and these kind of, and then psychedelic related types of referrals.
Yeah, well, I appreciate you sharing that. I know when it comes to mental health, it can be very debilitating for some people to do day-to-day activities, depending on what condition they have. Why do you think it's so hard to treat mental health condition overall, since you see that all day?
I actually don't think it's that hard. I mean, it's like any other profession. If you know what you're doing, it shouldn't be that hard. So, with combat trauma, the way that I developed a protocol to treat that was really based on what I heard from veterans when I first got back into therapy, was all of the negative stories they had about their treatment experiences at the VA. So the more I listened to there was a consistency in the complaints. So basic complaint, you show up for an appointment at 11 o'clock in the morning and you don't get seen till 2 o'clock in the afternoon. Like, well, okay. That means for me as a therapist, I need to show up for my appointments at least 2 minutes early. And something that's simple, for me, you'd be surprised how much that buys you as a therapist when you actually treat people and say, your time is just as valuable as mine. And so I'm going to make sure you get here on time. I'm going to get you in on time. So just the timeliness, being able to get in. And then the primary treatments of PTSD at the VA are prolonged exposure and cognitive processing therapy. Well, cognitive processing therapy is really kind of like cognitive behavior therapy, focusing on, thoughts, beliefs, repetition, kind of getting stuck in your head with certain thoughts. Prolonged exposure, on the other hand, is it's an exposure strategy where you're having people purposefully think about in detail the nature of the trauma. Well, for some people, doing that right off the bat is too much. I mean, they've been trying to not think about these things for years. In the case of Vietnam veterans, they've been trying to not think about it for 50 years. So to go into the VA and say, now I want you to just think about it. We're going to be here for about an hour, and as soon as we're done, I'm going to send you home. Well, even the VA's own studies suggest that there's an 87% dropout rate in prolonged exposure. So in that sense, it's not really an effective treatment if only 13% of the people stick it out. So thinking about what their experiences were, it's like, okay, well, we still need to get them to think about it. But we don't have to do it in such an aggressive manner. And it struck me that you shouldn't be re-traumatizing people when you're trying to treat them for trauma. So I just, listened more about what's going on. I listened to the spouses, which is another thing that the VA didn't do. And I still think they do a pretty poor job of, they don't bring spouses into any of the work. So, if you're diagnosed with cancer, you're married, your cancer doctor is going to say, you need to bring your spouse in for a meeting because they're going to be living with this as well. So I insisted then that as people were coming in, that their spouses be involved. And if they have kids, if they're like 15 years and above, bring them in if they feel like those kids are being affected. And then the rest of the treatment really, really started by listening to the problems that the spouses were talking about, and then developed an in vivo exposure, kind of like treating a phobia, an in vivo exposure protocol that was based around the two primary concepts, or three. One, PTSD is an injury, not a mental illness. And for a lot of combat veterans, when you say, look, you're not mentally ill, you've been injured.
That's a great point. That's a great point. I would have never thought of it that way, I guess.
Well, if you think about just more recent history, think about COVID and all the physicians, the nurses, the techs, the support staff, all these people in emergency departments and ICU at the beginning of the pandemic, they're getting all these people in and they're dying horrible, lonely deaths. Mm-hmm. So these professionals are going in probably perfectly mentally healthy. And then at the end of it, a lot of them have developed PTSD. So what I reflected was like, well, do you think that those people are now mentally ill, or would you say that they were scarred by their experience, right?
Yeah, and I love how you were saying that you involve the other family members as well, because that they go through the same process, or they may be able to help the the person at home or other places, I guess, or depending on what the situation. And also you're treating the whole person in a holistic approach, which is really important. So I can see why there needs to be maybe a little bit more added training to do what you're doing, right? So to understand what people go through and their experience, to be able to really listen and help. I'm assuming that's a whole different level of when we talk about, for example, depression, bipolar. I believe like this is a whole different level by itself based on what I'm hearing.
It's different. And also, and my thing is working with combat veterans or first responders. You also have to, as a clinician, you have to have buy-in, right? People have to trust you.
Definitely.
Because they're with the PTSD, especially, in some cases where guys have said, I know I committed war crimes. I know it. And they feel horrible. They feel guilty, but they're not going to tell their spouse that they committed war crimes. They're not going to tell other people. But for me to be able to be on this receiving end and say, well, okay, I'm not going to judge you for it. Let's hear it, because we're probably going to need to talk about it more to deal with the guilt associated with that. So you have to build with this group a different level of, I would say a bond, because there's some veterans who call me brother, which is a huge compliment.
Yeah.
Because they understand that I understand. And when I say I understand, and where the spouses sometimes come in is, how are you actually living now with this? So I said there were three primary things that I work around. One is that PTSD is an injury, not a mental illness. Well, right off the bat, guys' faces light up. It's like, you mean I'm not crazy? It's like, no, you're not crazy. You're injured. And, say, look, there's evidence to suggest that there actually are structural changes to the brains of people with chronic PTSD. So this is, in fact, an injury. And as such, you and I are not going to be doing therapy. We're going to be doing rehab. So again, it's using the language of the military, language that they're comfortable with. Let's get away from mental illness and therapy. You've been injured, you need rehab. They're used to that.
Yeah.
Right? Argues like, I blew out my knee, I need physical therapy.
Yeah, I like the way you put it. I really do. It gives us a different perspective.
And then that gives them buy-in. They're not threatened by what we're doing because we're not treating craziness. We're treating an injury. So that's key to kind of just get people to relax a little bit. The other two concepts are the relationship between warrior mentality and civilian society and their civilian life. So, I go through this and say, look, the military does a wonderful job training warriors. You go 6 weeks in basic training, you learn how to protect yourself and those around you, you get deployed, and depending upon where you're deployed, you learn additional strategies to protect yourself and those around you. And you develop a warrior mentality, which is great when you're in a combat area. But when you bring that warrior mentality back home, because it's out of context, what had been an adaptive coping strategy is now maladaptive. So
that is such a true, powerful statement. You can actually apply that in any other category of your life, depending if you've had a traumatic event, right? You've had to fight, and I'm just making this very basic, simplistic. Any traumatic injury, you have to kind of adapt and cope and become this warrior, I guess, if you want to call it. But then it may not apply to other places in your life when that traumatic event is now over. So that's a really nice concept, and I appreciate you explaining that.
Yeah. So this warrior mentality when people are out, I was like, and this was like thinking about pre-COVID, when you're out with your family, you and maybe your wife and maybe 2 or 3 kids, where do you walk relative to your family? And most of them will say, I walk behind, obviously. Like, now I know what they're going to say, because they're walking behind because they're covering their six, they're covering the rear, and then they can scan the area in front of their family for any threat. So they're covering the threat from behind, and they're scanning in front for any threats that might be coming at them. But what that then means is they're disengaged from their family, right? Or they go into the store, and the veteran will stay outside the store, in essence, standing guard, making sure that their family is going to be safe and keeping an eye on anybody who might be going to the store who could look dangerous. So and that's kind of a simple, just one of the simple ones when you're with your family. Not, so again, very simple, but people don't think about it. Veterans rarely carry things in their right hand. They don't. When I mention it, I was like, do you ever carry, when you go to the grocery store, do you ever carry bags in your right hand? Do you ever hold your spouse's hand with your right hand? And they think about it, I was like, no, actually, I don't. And in part, that is because they were trained their right hand, two things. One is they need their right hand available always in case they need to salute and in case they need to access their sidearm. And so they still keep doing this and they're not necessarily aware of it. So that's part of that warrior mentality. Going into a stadium, it's not that they're worried about crowds, is they can't do proper threat assessment with 35,000 people because they can't check under everybody's coat. They can't check everybody's bag.
Wow, that's pretty amazing. Like I'm thinking as you walking us through this, like who would ever thought that? Like, you know what I mean? Like that's really amazing to put in that perspective. And so you got all this by the educational or the program that you wanted to learn, or really, like I feel like you had to be there to go through that trauma to come back, and you had to be in it to be able to understand all these. So I can see why, again. And I say this with respect, with typical quote unquote clinician, like a clinician or psychiatrist, however you want to call it, may not be able to, treat accordingly, because I don't know if everybody thinks this way when they see a patient with PTSD.
So, this is kind of my approach with everybody, but part of it is, it's what the concept, I think you might have even put up an article about this before, that it's one thing putting yourself in somebody's shoes. It's another thing putting yourself in somebody's head. Most people, when they say, oh yeah, like if I was in that person's shoes, I would do this, 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 and this. Well, to me, what that means is you have no idea what you're talking about. Because if you actually put yourself in that person's head and you had the same thoughts that that person had, you would do exactly the same thing. If I'm walking around and I'm constantly looking around because my amygdala is enlarged from all the excess blood flow and glucose because of the trauma, and in my head, I'm thinking, I have to look out for threats against my family. I have to look out for threats that are coming from outside into my home. Well, once you understand that somebody has that thought or the general belief system, all the rest is easy. You can predict all the behaviors.
Very well said. Very well said. I think you're talking about, and we had this discussion before, mentalization is different than empathy, right? So I think that's the concept you're talking about. And maybe I will actually put that in the show notes, because I don't think I knew mentalization and the true meaning of it is really putting yourself in someone's mindset before even you figure out how they feel. So it's a little step before empathy comes, right?
And you need to actually have that step. And, yes, there's empathy, but you can have too much empathy and then you get lost as a clinician. Yeah. So my job is to try to stay objective. So I understand that the way that people think, like with regards to the combat stuff, I understand that the way they think has a perfect logic. The problem is the logic is based on irrational assumptions.
Can you say that could be a cognitive distortion?
It's a cognitive distortion. They're not aware of it. But all cognitive distortions still make perfect sense.
Yes, as a person thinking it, that's true.
Right? If I like treating a person for a fear of heights, they're not afraid of heights. They're afraid of falling from a height, because a lot of people with a fear of heights still fly in airplanes. So it can't be really afraid of heights. Someone who's really afraid of heights is actually afraid of somehow accidentally tumbling out of a window.
Yeah.
So if I know the person is saying, I'm afraid of falling out of a window, well, then it makes sense that they could go up to the 100th floor in the Empire State Building. They just won't get out of the elevator. I get it. So with the veterans, it's like, if you maintain this idea that there's threat everywhere and that it was drummed into you in basic training and then when you're deployed, Always be aware of your surroundings because you never know. When you let your guard down, if you stop paying attention, people get hurt and killed. So if you pull that mentality back into your civilian life, then it makes perfect sense that you would be suspicious of almost everybody you run into.
Yeah, and the anxiety level would be running up the roof for sure.
Right.
If you had to every time go out, now I can see it. Now I can see what you're talking about.
Right. And so then the next one, this warrior civilian mentality, is the connection being a FOB or forward operating base in your house. So when you go to your forward operating base, whether it's, Iraq, let's just use Iraq as an example, and you're inside the wire, you're inside the base. You can eat, you can catch some sleep, you can shower. You're never relaxed though. You can be comfortable because people are looking out for you and people are guarding and there's a fence, but you're never relaxed. When you go home, a lot of these guys treat their house like a fob. They lock the doors, they check the locks constantly. They either close the blinds all over their house so people can't look in, so they can't be targeted, or they keep all the blinds open so they can look out to make sure they can see anybody, potential enemy or threat approaching their house. They might keep multiple weapons hidden around their house. They booby trap or set indicators like taping doors or putting balls behind doors that would give them an indication while they're out. If anybody was in, they might set up all of these things around the house that let them know. When they come back home after being out, a lot of guys, they'll go through the house and they'll sweep their house room to room to room to room until it's clear, and then have their family come in. So they actually treat their house like a fob.
Yeah.
And so when you understand that, it's like everything else, all the behaviors flow from that, and it makes perfect sense. And so if someone is saying, I sit in my one chair and I sit there by myself, I only sit in this one location, I know they're sitting there because that place for them has the best view of the front door, a window, a hallway, and maybe there's some glass like in a window or a curio cabinet that they're using for the reflective surface to look over their shoulder. And really what they're doing is they're posting up in their own house. Yeah. And so they have to say, look, you got to keep the TV volume down. And some of these people will watch TV with no volume. They'll just keep the subtitles on so that they're able to hear, is there a potential threat coming to my house?
Oh my God, that's a lot. That's a lot going in their head. That is a lot.
Right. But once you understand all of these things and you can conceptualize it that way, then the approach I take is, okay, look, there is no way that you're going to be comfortable anywhere if you can't be comfortable in your own home. So the goal, the stated goal of rehab in PTSD is to be able to go wherever you want, whenever you want, comfortably. Because a lot of them will go wherever they have to, when they have to, but they're muscling through it or they're white knuckling through. And if you can't, and I tell them, if you can't depending on how you're thinking, throw the blinds open, put your earbuds in, blast some music, lay down on your couch, close your eyes and take a nap. Because that's what civilians do. We got to get you to that point in your house before we start getting you comfortable outside. Yeah. So therefore I start with them this way, doing that kind of behavioral rehab. And once they're comfortable in their house, then I get them out in their backyard, their front yard, their neighborhood. And then once I can get them to the supermarket, because the supermarket's a great location to do this kind of work, because there are all these different smells. There are people they don't know. There are people coming up around corners. You can't see over the top of the aisles. You might have to stand in line. Most people treat going to the supermarket then as a mission. I've got no more than 5 things on my shopping list. I know exactly where they are. I'm going to back my truck in at the end of the parking lot in case there's an emergency. I can pull right out. I don't have to worry about backing out of a space. I'm going to get in there. I'm going to get the 5. I'm going to go self-checkout. I'm going to get out there. I'm going to check my watch to see how much time I actually took. And then I'm going to go home. And so they treat grocery shopping as a mission.
Oh. I feel like now that when I go out, I'm going to look at things differently just because of that. I have this new thought process just you are educating us on in a good way.
Right. So in that sense, And now that I've laid that out, the treatment is actually fairly straightforward and pretty easy.
Yeah, I can see that now.
Right. And then
Right.
once they're comfortable, and then I say, now we've got to get to the part where we're talking about the trauma. But now they can do it in the comfort of their own home where they're actually comfortable. Not in an office at the VA or not in an office like at my old clinic. You're going to do this really hard work in the comfort and safety of your own home. And I break it down instead of doing the all, just shove your memory back up. I said, look, we're going to break it down because traumatic memories are different than working memory, right? Traumatic memories, you've got the visual, it's kind of obvious, but what you were thinking at the time of the trauma gets encoded in the memory. What you were feeling at the time, the emotional response gets encoded in the memory, and all of the sensations that were engaged get encoded in the memory, which is why anything can trigger an unwanted memory. So
that's true.
Right? So we break down the memory into those components. I just want you to give me a factual accounting, period. A chain of command, didn't really care what you thought about it. They don't really care how you felt about it. They don't care what you smelled. They just want to know what happened. So we break it down into those various components, but I have them use the strategy of saying, look, there's the content which is distressing, but for some people, even more distressing is the uncontrolled nature of when they have them. So we got to practice starting a memory and stopping it, and starting it and stopping it, and starting it and stopping it. Again, kind of this rehab model.
Mm-hmm. Yeah.
Right? So you start writing, and on a subjective units of distress, like 10 being a panic attack, 1, you're perfectly comfortable. You get to a 5, I'm telling them, I want you to close it up and walk away. Even if you've only written 1 or 2 sentences, it's fine. Because we want to disconnect the memory from the physical reaction to it. And we want them to be able to practice starting and stopping so it becomes more volitional. And it appears to them to be less out of control.
Well, that's a beautiful work you're doing with everyone. We all appreciate what you're doing. You're really saving lives and family and, jobs and a lot on every single day. You really are. Can you tell us about that one patient that we've talked about that you found that might be valuable to do a PGX test, and how she came to you and what your thoughts were and why you thought a genetic testing will be valuable? Talk us through that.
Well, to preface that, before you did, one of the things that I noticed about veterans in particular was they would come to me after being treated at the VA, and so many of them were coming on multiple medications. So the one that we were working on was just one of many. It was unbelievable. People coming in on 10, 15. I think the most I saw was 22.
That's crazy, insane.
Right. And the other crazy part of it is I could not find a physician to do anything about it. No one physician was willing to take responsibility for any other for any medications that any other physician prescribed.
Yeah, I can see that. I've heard that a lot.
So it was very, very frustrating for me to say, oh my God, I don't even know what I'm treating here. Am I treating PTSD or am I treating some kind of weird drug interaction? Because I'm not a pharmacist, but every once in a while I'll look up drug interactions, but I know that the stuff online, you're comparing 2 medications. But how do you look at 10, 15, or 20 and understand what the potential interactions are there? So for me, the idea of how am I going to treat people if I don't know what I'm treating? So when this person came in, I think she might have been on upwards of 10 or 15 medications. And she was originally referred for PTSD, military sexual trauma, but she also had a history of childhood physical abuse at home. So she was talking, and she was saying, I don't know how many mailboxes I've destroyed because I just don't know what I'm doing, or I don't know where I'm going. She was on taking medications. It's like, wait a minute, that's for narcolepsy. You're taking medication for narcolepsy. You're falling asleep, but you're on all these other sedating medications. And that's when I was like, oh my God, it just gets frustrating. So you can tell that whoever was prescribing medications to deal with the side effects of the medications that they had prescribed earlier, which weren't really doing anything for the PTSD anyway. So for me, it was, when I ran this by a couple of physicians, most of the physicians were like, yeah, this is malpractice, but they weren't willing to take it. So I was routinely referring patients to their pharmacist. Even before you and I started speaking, I would routinely refer people to their pharmacist, like, listen, you got to get somebody to look at this mess. And I think the best person to look at this is going to be your pharmacist, not your doctor. I just don't know how many pharmacists at the time, whether it's a small local pharmacist or the local CVS or Walgreens, whether or not they had access to any of the genetic testing. So once I found out that that was available, I was like, man, if I'm going to treat the whole person, I may be a psychologist, but I got to get the medication issue straightened out. Otherwise, I can't work with these people because I don't know what I'm treating. And so that's why, I was referring, for the genetic testing, because not only the genetic testing, like how are they metabolizing these medications and what's going to work with and what may not, or what might work better, it's going to get the physician to start thinking differently about how they're using the medications. And maybe opens their eyes to say, well, maybe there are some medications that I can actually, maybe withdraw or change. So I just saw it as like, as we're doing more targeted therapies, why would you not do this? Frankly, I actually had a call the other day, somebody who was referred for psychedelic-assisted psychotherapy, and he was talking about the use of mushrooms. And he brought up this idea, it's like, I don't respond to medication. I've been told I'm a fast metabolizer. I was like, well, look, before we get into any of this talk, I want you to reach out to, I want you to reach out to Ben Oz. I gave him your contact information. I want you to reach out to this person, because if you're being told you're a fast metabolizer, you're going to work with mushrooms. I have no idea how that gets tested, but maybe you should just find out rather than just keeping drug after drug after drug. Why don't you just get the testing done and find out maybe what's going to work better for you up front rather than the trial and error approach?
Yeah.
So for this particular woman, I forget how many medications she's on now. It's a lot less, but far less suicidal. She's running her farm. She got a job also where she's interacting with the public. She's going to church on a regular basis. She just went on a trip to visit friends. So from the time I saw her to now, and I think really the clarity was getting her off of and really, really fixing her medication schedule. Yeah. In the absence of that, there's no way she would have made the progress that she's made. She was too lethargic. She was too confused. She was too unmotivated. It was awful. It was awful to look at. So it just made my job a lot easier. Now it's like, oh, okay, now I know what I'm dealing with. And then we can work on the protocol. And, her life is almost done a 180.
Yeah, I'm happy to hear that. It really, I know who, I have spoken with her. So it's nice to have those really dramatic changes and her actually getting back to her life. It really makes a huge difference. And so, and that was my other thing I was going to ask you, how you see pharmacists working alongside you if you had one right in your practice, but you already answered a lot of that question already. So, yeah.
Yeah. I think, personally, I think if I hadn't seen so many people coming in on polypharmacy, I may not have thought about utilizing pharmacists. But once I started seeing how prevalent it was, at least in the veteran community at the time, and that physicians were not willing to do anything about it, I also understood that realistically, that's not even their job, is to be able to understand all those drug interactions, that the real professional to help me there is going to be a pharmacist, not a physician.
Yeah, that's exactly right. And so, a teamwork always is better. So you can have the individual, you guys treating on behavioral therapy, cognitive therapy, however way you do that. And then, helping alongside you would be a pharmacist that knows their medications and interactions and pathways. And, interdisciplinary, team is always best. And I've always advocated for that, for sure.
And early in my training, when I was actually still in graduate school, I worked at a day treatment facility in the Sunset District in San Francisco. And there was actually a head pharmacist actually at the day hospital. And I can't remember his name, I remember his face, but he also ran therapy groups. So not only were people coming in to get their depot medications, and their oral medications from him, but he was actually running groups. And he wasn't running groups about medication. He was running groups about their mental health. Now, these people were very, very, a day hospital in the Bay Area at that time, after deinstitutionalization, we're talking about some really, really, really impaired people, really impaired. But it was a deinstitutionalization period. And like I said, at the time in the Bay Area, pharmacists were doing, where I was, they were doing therapy. They were also allowed to instigate a 72-hour hold if they thought it was necessary.
Yeah. Well, that is a really amazing story about that one patient. I know that's just not the only one. I know you probably see a lot. But is there any other stories that you want to share about when you had a patient that come in and you're like, well, I guess what I'm trying to say is, how do you determine this individual that you're seeing outside of multiple medications that would be a good candidate for you doing a genetic testing? How do you figure that piece of it out?
If someone tells me that they come in and they say they've tried all these medications, let's say they tried all of the SSRIs, and we know you only really need to try 2, and if you fail both, using the other 3 or 4 or 5 aren't going to do anything. But if someone is just not responding to anything, medication-wise, first I might think, well, not everybody responds to medication, so that's that part, and not all psychiatric medications. We know like the SSRIs, maybe 30% of the population get really good response. Another 2/3 are going to get moderate to nothing, but a lot of side effects. But if someone's saying, I've tried everything, I was like, well, that would be one of those cases, like, you might want to consider genetic testing to see how you're metabolizing these medications, and are there classes of medications that may work better, as opposed to, again, going back and because it's a long-term process, right? If you're saying it's going to take 6 to 8 weeks to know whether or not an SSRI is going to work, and then another, let's say 4 weeks, if you're going to add and add and add and add, by the time you figure out, well, this is going to work, you could be 6 months in.
That's absolutely correct.
Well, then why not just get it all done up front?
Yeah.
So that would be a reason if someone's saying nothing works. Like, well, we got to get you tested. Really, frankly, Ben, the hardest part about it is, while I've made a number of recommendations and referrals, the hardest part is actually getting the patients to follow through. Because a lot of times they're sheepish about going back to their physician, because in some ways they're worried that, I think what's going on is they're worried that they're questioning their doctor.
I can see that.
Hey, nothing's working. Can we try this? Most people don't advocate for themselves nearly enough with their medical providers the way that they should be.
That is very correct.
Right. So I think if people were more, felt better about advocating for themselves, when I said, hey, I think you need to talk to your doctor about this, or, here's Banaz's information, get in touch with her, I think they're just intimidated in part by questioning their position. Mm-hmm. Some are worried about the cost. I'm like, well, that's, you got to ask the questions. But
absolutely.
Right. And then I guess a couple have run into situations where their physician just poo-pooed the idea. And then it just got dropped.
Yeah.
Right. So I'm finding that there's, getting buy-in from patients is tough, or maybe not getting buy-in from patients, but getting patients that advocate for themselves, and not just advocate, but because this is an area where they're saying, I know you're trying your best, doctor, but we've got to get away from people to say, you know what, I'm coming to you because you have knowledge that I don't. My insurance company is paying you to give me that knowledge and help me out here. And be okay by just asking questions.
Mm-hmm.
I mean, that's really right now the hard part.
Yep, exactly. That is. We have to have you have you come back, Dr. Shapiro. It's been such educational, at least for me. I know for listeners as well. I don't think one session or one podcast is enough. I hope you come back. I hope this was fun. You said, is this the first one? Yes. I hope you do come back and share patient stories and educate us on the types of mental health conditions you treat and how, and give us a different mindset. I know there's pharmacists majority listening, but there's also a lot of other professionals listening on here that they can learn. So I hope you do decide to come back and share your story. But I wanted to give you the platform to see if there's one takeaway or two. I know we had a lot that you want listeners to take away from our discussion and learn. What would that be?
Ooh.
I know you have many.
All right. So I guess the one of the things that I guess it would be great for people to understand is the brain is an organ, and people do not treat their brains as an organ. They treat it as a brain. So that they don't have a problem saying, I'm going to treat my heart, I'm going to treat my liver, I'm going to treat my kidney, I'm going to treat my lungs. I'll take whatever medication, I'll do whatever rehab, do whatever to keep those internal organs healthy. People have to start thinking about their brains as an organ that sometimes doesn't work well, an organ that sometimes gets injured, an organ that sometimes gets sick. The analogy that I use for people is like, if you're sitting at home, you're like, you know what? I want a really good cheeseburger. Then you're saying, all right, you know what? I'm going to go out to the local bar and I'm going to get a really good cheeseburger. But you don't say, I'm going to go to McDonald's to get a quarter pounder with cheese. Now, on the other hand, sometimes you might say, you know what? I'm in the mood for a quarter pounder with cheese. You're not going to go to the corner bar and get a hamburger with cheese. You're going to go to McDonald's to get a quarter pounder with cheese. Technically, a quarter pounder with cheese is a cheeseburger, but no one thinks about it as a cheeseburger. They think about it as a quarter pounder with cheese. People need to think of their brain as a quarter pounder with cheese. It is still technically an organ. It's an organ, and you got to treat it just as sensitively as you treat all the other organs in your body. Don't treat it differently. It's actually the most important organ, but you got to think of it as an organ that gets disrupted just like any other organ in our body.
That's very well said. Yes, it is the number one. I love that. Next time I have a cheeseburger, I'll have to think about that, which is lunchtime, so it's making me hungry. But that is true, because really everything starts with the brain, right? You think before you feel. So that's a really important organ. Everything starts there. So that's a very nice analogy. I think it's very relatable, and we can all remember that. And I appreciate you. So I appreciate you coming on. Again, like I said, we have to have you back, hopefully. Another podcast. But thank you everyone else for listening to the Continuing Education Division of Pharmacy Podcast Network that's powered by Convey Med. Download the Convey Med podcast app, and subscribe so you can listen to all our podcasts. There's no other place to go for all your PGX needs. We do a lot of PGXing on here, the science, the business, the reimbursement piece, and patient story, just like Dr. Shapiro just did. We want to hear from you. So let us know what you think by leaving us a review, and let us know what you want to hear more on our next episode.
Thanks for your interest in PGX and for spending some time with us. Please share this podcast and leave us a review on Apple Podcasts or Spotify. For all of our episodes, please visit pgx4rx.com. That's pgx4rx.com.